Welcome to the Rad-On Smart Review CNS Cancer Series. We're here to sharpen your clinical acumen and get you board ready, focusing on those crucial details that truly make a difference in patient care.
Today, we're embarking on a focused exploration of a fascinating, though sometimes overlooked, corner of radiation oncology: the management of rarer benign conditions within the CNS and ocular regions.
Yeah, these aren't your everyday gliomas or meningiomas, are they?
Not at all, but mastering them is absolutely essential for every well-rounded radiation oncologist. They really test the breadth and depth of your knowledge.
That's precisely it. While we dedicate significant time to the high-volume malignant cases, these unique benign conditions, each with its own distinct pathology, clinical presentation, and, well, very specific treatment principles, are incredibly high yield.
Mm-hmm.
They frequently appear on board exams and, in real-world practice, often catching you off guard if you haven't reviewed them recently.
Our goal for this session is to provide you with a highly structured and hopefully memorable review. We'll anchor our discussion with classic clinical vignettes,
Okay.
walking through the process of diagnosis, understanding the nuanced treatment rationale, and, crucially, pinpointing the precise radiation doses for 4 distinct diseases: paragangliomas, Graves' ophthalmopathy, CNS hemangioblastomas, and pterygium.
4 key conditions.
Exactly. We've broken these down into manageable segments, ensuring that the key information and the why behind it really sticks with you.
Okay, let's unpack this with our first classic scenario, a presentation you'll likely encounter. Imagine a 60-year-old woman walking into your clinic.
Okay.
She's been troubled by a persistent pulsatile tinnitus. That's that kind of rhythmic whooshing or throbbing sound in her ear, synchronized with her heartbeat, and some progressive hearing loss, specifically in her left ear.
Pulsatile tinnitus.
Well,
Red flag right there.
right. And on physical exam, when you perform otoscopy, you observe something quite striking:
Mm-hmm.
a reddish-blue mass visibly bulging behind her tympanic membrane.
Yeah.
An MRI is ordered, and it dramatically reveals a highly vascular salt and pepper lesion precisely located within the jugular foramen.
Ah, the salt and pepper sign.
Yeah, for many of you listening, this presentation is ringing a bell, isn't it? It's highly consistent with a glomus jugulare tumor.
Indeed, that's a textbook glomus jugulare, a type of head and neck paraganglioma, or HNPGL. These are fascinating neuroendocrine tumors originating from paraganglia, those extra-adrenal chromaffin cells.
Right.
What's particularly important about HNPGLs is their genetic predisposition. We often find that approximately 30 to 40% of these tumors are actually heritable, linked to germline mutations.
30 to 40%. Wow.
Yeah, significant. This means genetic testing, specifically an SDHX panel, which looks for mutations in succinate dehydrogenase genes like SDHB, SDHC, and SDHD, is frequently appropriate. It's not just a nice-to-have, it's really a critical component of their workup.
So standard practice now.
Pretty much becoming standard, yes. And here's a vital clinical pearl for your practice. SDHB mutations are specifically linked to a significantly higher risk of metastatic disease.
Okay, that's huge.
It absolutely is. This fundamentally redefines what we consider benign in these patients, right? It transforms our long-term surveillance strategy from purely local control to systemic vigilance, emphasizing the need for comprehensive follow-up.
That genetic link, particularly with SDHB, is absolutely a game changer for surveillance and patient counseling. But before we even think about intervention, whether it's surgery or radiation, there's a mandatory first step in the workup for any head and neck paraganglioma, regardless of its apparent size or location.
Absolutely mandatory.
We're talking a biochemical screen,
Yeah.
plasma-free, or urine-fractionated metanephrines.
Yep. Metanephrines.
These are metabolites of catecholamines,
Right.
adrenaline and noradrenaline. We're meticulously looking to rule out a functional catecholamine-secreting tumor.
Because if you miss it,
Exactly. If you miss this and proceed with any invasive procedure, be it surgery, an angiogram, or even, say, a radiation simulation that induces stress, you risk precipitating a catastrophic, potentially fatal hypertensive crisis.
it's a can't-miss diagnosis.
It's a non-negotiable step for patient safety. Now, for staging, especially in those cases where hereditary syndromes are suspected, and we know multifocal disease is a real concern.
Like with the SDH mutations?
Right. Gallium-68 dotatate PET-CT is the preferred imaging modality. These tumors are highly somatostatin receptor avid, meaning they have specific receptors that bind to somatostatin analogs, allowing the PD scan to effectively light them up.
So it finds other spots.
Precisely. This helps us detect additional lesions throughout the body that might otherwise be missed on conventional imaging.
That's a critical point about the biochemical screen. It's a board favorite for a reason, given the potential severity of missing it. So let's talk management. While surgery has traditionally been an option, it carries substantial risks.
Especially there in the jugular foramen.
Exactly, particularly to the delicate cranial nerves in that region, nerves 9, 10, 11, 12, glossopharyngeal, vagus, accessory, hypoglossal. Postoperative deficits can be significant.
Life-altering
They
deficits.
can be. This is precisely where radiation therapy truly shines. It's now recognized as a primary treatment option, especially for glomus jugular tumors, offering excellent tumor control rates,
How good are we talking?
often exceeding 90 to 95%. And importantly, with significantly lower morbidity compared to expensive surgical resections. This makes it a compelling choice for many patients, preserving quality of life by minimizing functional deficits.
So the thinking has shifted a bit.
Yeah, the paradigm has really shifted towards a more nuanced, individualized approach, where radiation often takes the lead, particularly for larger lesions or those intimately associated with critical neural structures.
This is where it gets really interesting for us as radiation oncologists.
Yeah,
The specific treatment techniques and doses. We have a few excellent modalities at our disposal.
options are good.
Right. For conventional external beam radiation therapy, or EBRT, a very standard and well-established approach is 45 to 50.4 gray delivered in 25 to 28 fractions.
Okay, standard fractionation.
Yeah. This provides excellent coverage and long-term control, often with minimal toxicity due to the fractionation. Then, for stereotactic radiosurgery, or SRS,
Single shot.
right, single high dose, ideal for smaller tumors, typically less than 3 centimeters, that are well away from critical structures. A dose of 12 to 15 gray to the tumor margin in a single fraction is standard. Highly conformal, ablative dose, very precise.
But not always feasible, right? Especially in that location.
Exactly. What about those cases where the tumor, like our glomus jugular example, abuts lower cranial nerves or the brainstem? That's incredibly common in the jugular foramen region.
Very common.
Here, hypofractionated stereotactic radiation therapy, or SRT, is an excellent choice.
So breaking it up a bit.
Yeah, a regimen of 24 to 27.5 gray delivered in 3 to 5 fractions. This helps lower the dose per fraction to these critical structures, maximizing safety while still delivering a potent biological dose.
Allows for some normal tissue repair between fractions.
Precisely, greatly reducing the risk of cranial nerve injury. Across all these modalities, the control rates are exceptionally high, over 90 to 95%, and crucially, we see excellent rates of cranial nerve preservation. That's really the goal, isn't it? Quality of life.
Absolutely. That's a fantastic breakdown of the technical options, and the radiobiology here is key. These are often slowly growing benign tumors, so fractionation, even hypofractionation, works incredibly well because the alpha-beta ratio for benign tissues often favors fractionation, meaning it allows for better sparing of surrounding normal brain tissue and critical nerves compared to a single high dose. So bringing it back to our 60-year-old patient with that glomus jugular,
Okay.
assuming her biochemical screen for metanephrines came back negative again, an absolutely mandatory first step.
Cannot stress that enough.
Cannot stress it enough. I would definitively recommend radiotherapy. Given the tumor's intimate proximity to the lower cranial nerves and the jugular foramen, an area fraught with delicate structures where even a millimeter matters, a fractionated approach would be my preference.
Safer bet.
Much safer. Either 50.4 gray in 28 fractions or a hypofractionated stereotactic course like 24 to 27.5 gray in 3 to 5 fractions. Both excellent choices to maximize safety and preserve cranial nerve function.
Like that analogy you used.
Ah, the master electrician. Yeah. Working near intricate, delicate wiring, you'd rather make several small, precise adjustments with specialized tools than one large, potentially damaging cut. Fractionation allows for that exquisite precision and the spreading out of the dose over time, letting normal tissues repair.
Makes sense.
And just to reiterate, if her metanephrines were positive,
If
huge if, she'd absolutely need to be started on alpha blockade before any intervention could proceed. You simply cannot underscore that enough. Patient safety is paramount.
that analogy of the master electrician really drives home the benefit of fractionation in such a sensitive area. Now let's pivot from the skull base to another area demanding our meticulous attention. The orbit.
Okay, moving to the eye.
Our next clinical scenario involves a 45-year-old woman with a history of Graves' disease. She's now euthyroid, meaning her thyroid hormone levels are normal after her initial treatment.
Good, thyroid controlled.
but she presents with persistent and progressively worsening diplopia double vision.
Oh.
She's already tried and failed a course of high-dose steroids, and this debilitating visual disturbance is significantly impacting her quality of life, making daily tasks incredibly challenging.
Right. This is a classic presentation of Graves's ophthalmopathy, also widely known as thyroid eye disease. It's an autoimmune disorder.
Immune system attacking the orbit.
Exactly. The immune system mistakenly attacks tissues in the orbit, causing significant inflammation, expansion of the extraocular muscles, and an increase in retroorbital fat behind the eye.
Pushing the eyes forward sometimes.
Yeah, that's proptosis. But for radiation therapy, our primary indications are quite specific. We're generally treating for inflammatory diplopia, as in our patient, or for compressive optic neuropathy.
So the double vision or nerve compression.
Precisely. We intervene during the active, moderate to severe inflammatory phase of the disease, aiming to manage those active inflammatory symptoms that truly impact vision and quality of life.
And it's the inflammation we're targeting, not the bulging eyes themselves.
That's a key point. Radiation primarily targets the inflammatory component, which translates to improvements in motility and diplopia, but it's not typically used for proptosis reduction. That's often better addressed surgically or now with newer systemic agents.
What's truly compelling here, and often a pleasant surprise for many, is that the evidence for radiation therapy in Graves' ophthalmopathy is incredibly robust.
Yeah, we have good data.
We have randomized data, the gold standard clinical evidence, actually supporting the use of 20 grays in 10 fractions versus a sham treatment.
Randomized data, that's strong.
It is. This evidence has shown clear improvements in both ocular motility, meaning how well the eye moves, and crucially, in the patient's experience of diplopia. This makes orbital radiation a very effective and evidence-based tool in our armamentarium for these specific debilitating symptoms.
Especially when steroids haven't worked.
Exactly, especially when steroids have failed. It's not just an adjunct, it's a proven treatment.
And here's a critical counseling pearl one you simply must emphasize with your patients. Smoking cessation is non-negotiable.
Smoking always comes up.
Always. Smoking is a significant risk factor for the development of Graves's ophthalmopathy, and it dramatically worsens both the underlying disease itself and, importantly for us, it diminishes the positive outcomes we can achieve from radiation therapy.
Makes the inflammation worse.
It really does. The inflammatory process is exacerbated by smoking, making treatment less effective. So, vigorously counseling your patients to quit smoking is a vital part of their overall management and prognosis, impacting their vision and quality of life long term. This is a point that often comes up in board exams because of its profound clinical relevance.
When we talk about the practical application of radiation therapy for Graves' ophthalmopathy, the dose is quite standardized. We're looking at 20 grays delivered in 10 fractions.
20 and 10, the standard.
Right. While some smaller series have explored similar efficacy with 10 grays in 10 fractions, 20 grays in 10 fractions remains the established board standard and the dose most commonly applied in clinical practice.
Okay.
The technique involves carefully treating the retroorbital tissues, which specifically includes the inflamed extraocular muscles and the crowded retroorbital fat that are causing the compression and inflammation.
So, behind the eyeball.
Exactly. We typically use lateral opposed fields to encompass the entire orbital contents, but this requires meticulous lens sparing and shielding.
Crucial. Got to protect the lens.
Absolutely. Protect the sensitive lens from cataract formation, which is a key potential toxicity. A medial canthus block is also often used as needed to further protect sensitive structures within the orbit, ensuring we're delivering dose precisely where it's needed while minimizing harm to surrounding healthy tissues.
Exactly right. And it's important to note the evolving landscape here. You'll hear about newer agents like the monoclonal antibody to pertuzumab.
Right, the newer drug.
Yeah, it's shown excellent results in randomized trials for improving proptosis. That's the bulging of the eye in the clinical activity score, which measures the overall inflammatory burden. These are exciting developments.
Definitely.
But radiation therapy still holds a key and highly effective niche specifically for that inflammatory diplopia. It's not really a competition, but more a complementary approach, offering targeted relief for a very specific and debilitating symptom. We might even see combined approaches in the future.
Makes sense. Use the right tool for the job.
Precisely.
So for our patient with steroid refractory inflammatory diplopia, given her significantly impacted quality of life and the strong evidence base, I would absolutely recommend low-dose orbital radiotherapy to 20 gray in 10 fractions.
Seems like the clear next step.
Right. This is a clear next step to alleviate her symptoms and restore her vision. Now, if a patient were to present with compressive optic neuropathy, meaning the inflamed tissues are pressing directly on the optic nerve, threatening permanent vision loss,
That's an emergency.
that is an urgent, even emergent situation. In such a case, I would initiate radiotherapy immediately, often on the very same day. This isn't something you delay.
No, waiting around.
No. Simultaneously, I would coordinate high-dose steroids and very close ophthalmology and neuro-ophthalmology follow-up to preserve their vision, as it's a true medical emergency requiring a rapid, multidisciplinary response.
Okay, good plan.
From the delicate anatomy of the orbit, we now shift our focus to the brain itself, where another intriguing benign condition can present significant challenges.
All right, back inside the skull.
Let's look at a 28-year-old man with known von Hippel-Lindau, or VHL, syndrome.
VHL, okay. Strong association coming up.
Yep. He presents with worsening ataxia, which is that lack of voluntary coordination of muscle movements, making him unsteady. An MRI of his brain shows a new, intensely enhancing mural nodule within a large cyst in the cerebellum.
The classic cyst with a mural nodule, textbook hemangioblastoma, especially with VHL.
Right.
These are CNS hemangioblastomas, benign but highly vascular tumors of the central nervous system. The key association here, as in our case, is VHL syndrome, an autosomal dominant genetic condition.
How common is the link?
About 25% of patients with CNS hemangioblastomas have VHL, and these individuals often present at a younger age, frequently with multiple lesions throughout their CNS brain, spinal cord, retina.
So screening is vital.
Absolutely crucial. Ongoing surveillance for their lifetime. Understanding the VHL context is essential for comprehensive patient management.
Here's a fascinating clinical pearl that's definitely worth remembering, maybe for boards.
Oh, I like pearls.
These tumors can actually produce erythropoietin, the hormone that stimulates red blood cell production.
EPO, like cyclists use.
Sort of, yeah. This can lead to secondary polycythemia, an abnormally high red blood cell count. So for a patient with a hemangioblastoma, always keep an eye on their labs, specifically their complete blood count.
Check the CBC.
Right, because an elevated red blood cell count, particularly hemoglobin and hematocrit, could be a sign of this paraneoplastic phenomenon. It's a great example of how a seemingly localized tumor can have systemic effects.
That's a great pearl and a definite board question favorite, highlighting the systemic impacts of some of these benign tumors. For management, surgery is generally considered the primary treatment when feasible.
Get the nodule out.
Exactly. Maximal safe resection of that enhancing mural nodule. What's absolutely crucial to remember, and this is a common point of confusion,
Okay, what's the pitfall?
the cyst wall itself is typically reactive. It's just a collection of fluid. It does not contain tumor cells. Therefore, it does not need to be resected or irradiated.
Just the nodule's the target.
Just the nodule. The true pathology, the active tumor, lies within that nodule. For radiation therapy, we consider it for unresectable lesions, recurrent lesions after surgery, or in patients with multiple lesions where surgery isn't practical or safe for all of them.
And the target for RT.
In these cases, stereotactic radiosurgery, or SRS, specifically targets only the enhancing mural nodule. The cyst wall is absolutely not a target volume. This is a key distinction that frequently comes up in discussions and on your board exams.
Got it. Nodule only. And when we do opt for radiation, particularly SRS, the dose is quite specific to ensure both efficacy and safety.
What's the dose?
The SRS dose is typically 16 to 20 gray, delivered in a single fraction. This high dose is delivered with exquisite precision to ablate the tumor while sparing surrounding brain tissue.
16 to 20 gray, single shot.
Right. However, for lesions that are adjacent to the brainstem or critical cranial nerves, a single high-dose fraction can be risky, potentially causing permanent damage.
Brainstem sensitive.
Very. In these situations, a fractionated regimen like 25 gray, delivered in 5 fractions, is a safe and effective alternative.
25 and 5.
Yep. This approach allows for better dose distribution and critical structure sparing by reducing the dose per fraction to those sensitive areas, taking advantage of the differential repair capacities of normal and tumor tissue. It's a way to maintain excellent control while significantly enhancing patient safety.
It's critical to counsel patients about a specific phenomenon, the possibility of transient cyst expansion after SRS.
The cyst can get bigger after treatment.
It can, yeah. This can occur in the first few months post-treatment and may sometimes require surgical drainage if it becomes symptomatic, leading to worsening headaches or neurological deficits like ataxia.
So warn them beforehand.
Absolutely. This is a vital piece of information to share up front so patients understand what to expect during their follow-up period. So for our VHL patient with a new symptomatic cerebellar lesion causing ataxia,
Okay, back to the case.
surgical resection of the mural nodule would generally be the first step, if feasible, to alleviate his symptoms. If, for some reason, the nodule were deemed unresectable, or if he had multiple lesions making surgery impractical,
Then radiation.
then SRS to 16 to 20 gray would be the standard of care for that mural nodule. And crucially, I would make sure to counsel him about that possibility of transient cyst expansion, coordinating rapid neurosurgical follow-up for drainage if his headaches or ataxia were to recur or worsen.
So close follow-up is key there.
Essential, ensuring we can intervene quickly to protect his neurological function.
That potential for post-SRS cyst expansion is such a critical counseling point, highlighting that even benign doesn't mean hands-off after treatment. Now let's move to our final condition, one that affects the very surface of the eye.
Okay, surface of the eye.
Pterygium, you got it. Imagine a 50-year-old fisherman, a classic presentation, with a long history of extensive sun exposure throughout his life.
Lots of UV exposure.
Right. He recently underwent surgical excision of a pterygium that was visually significant, encroaching on his visual axis. The problem, this is actually his second recurrence,
Recurrent. That's the key.
and he's now been referred for adjuvant therapy to prevent another regrowth.
This is a classic example of a pterygium, which is a benign, often triangular fibrovascular growth of the conjunctiva that can invade the cornea.
Grows onto the clear part of the eye.
Exactly. And as in this patient, it can significantly interfere with vision, causing irritation, astigmatism, or just obscuring the pupil. The key clinical problem we constantly face with pterygium management is its notoriously high rate of recurrence after surgery alone.
They just keep coming back sometimes.
They really can. Modern surgical approaches have significantly tried to mitigate this, often including a conjunctival autograft.
Using the patient's own tissue.
Yeah, where a small piece of healthy conjunctiva from the same eye is used to cover the surgical defect, or the intraoperative use of mitomycin C, an antimetabolite, to reduce recurrence by inhibiting the proliferation of fibroblasts.
The cells that cause scarring.
Precisely. Those are key to scar formation and regrowth. Radiation therapy, specifically, is typically reserved for recurrent cases like our fishermen, or for patients with high-risk features where those surgical adjuncts alone might not be enough to prevent another recurrence. It's a crucial tool in those challenging situations.
For adjuvant radiation therapy for pterygium, the standard approach is beta-emitter brachytherapy, utilizing a strontium-90 or Sexar-90 applicator.
Strontium-90, beta emitter.
Right. This is specifically chosen because it delivers a very superficial dose, precisely targeting the surface of the eye where the fibroblasts are active, with rapid dose fall-off, thereby sparing deeper ocular structures.
Superficial treatment.
Very superficial. And this treatment is most effective when delivered either intraoperatively, right after the surgical excision, or, crucially, within 72 hours post-excision.
Timing is key again, really soon after surgery.
The timing is paramount because we want to catch those rapidly dividing fibroblasts before they can establish a new recurrence and proliferate.
Get them while they're active.
Exactly. Common short-course regimens include 30 to 36 grays delivered in 3 to 4 fractions,
Okay, 30 to 36 in 3 or 4.
or 20-22 gray in 2 to 3 fractions. These are typically given over just a few days.
Shorter course, 20 to 22 in 2 or 3.
Right. With modern fractionation schemes and meticulous shielding, the risk of scleral thinning, a previous concern with older, higher doses or less precise techniques, is now quite rare.
So safer now.
Much safer. However, other potential risks, though uncommon, include cataract formation if the lens is not adequately shielded, and dry eye, so careful patient counseling is essential.
Manage expectations, mention risks.
Definitely. Inform them of these low but existing risks.
So for this patient, our fisherman, given his history of multiple recurrences and extensive sun exposure, I would definitely recommend adjuvant beta therapy.
Makes sense for him.
This is precisely the scenario where it provides the most benefit for recurrent disease or high-risk anatomy, especially after optimal surgery that already included a conjunctival autograft and mitomycin C.
So radiation is added on top.
Exactly. I would recommend strontium-90 brachytherapy to a dose of, say, 30 to 36 gray in 3 to 4 fractions, always with meticulous lens shielding to prevent cataract formation.
Shield the lens.
Always. To help remember the key aspects of pterygium treatment for your boards and daily practice, let's use the mnemonic PTER.
Okay, a mnemonic. I love it.
PDR, PDRO. Prescribe strontium 90 brachytherapy. Timing is critical. Early post-op, ideally within 72 hours. Exclude lens. Meticulous shielding is paramount. And recurrence risk reduces significantly with this approach.
PTER, prescribe SR90, timing critical, exclude lens, recurrence reduced. Got it.
Really helps to lock in those key details. All right, that was a thorough tour through some very specific conditions. Now let's shift gears and synthesize some high-yield clinical pearls from these conditions.
Yeah, let's consolidate.
To really cement the most important takeaways for your board preparation and daily practice, these are the nuggets of information that you absolutely need to have at your fingertips.
Excellent idea. It's time to consolidate and highlight those indispensable facts. Let's hit the highlights, because these are the details that often differentiate strong candidates and confident clinicians.
Okay, starting with paraganglioma. Remember these critical points. Pearl 1. Always, and I mean always, screen all head and neck paragangliomas with plasma-free or urine-fractionated metanephrines.
The biochemical screen. Mandatory.
Mandatory. To avoid a catastrophic hypertensive crisis, non-negotiable. Pearl 2. Consider SDHX genetic testing in all patients, given that 30 to 40% are heritable. And critically, remember, SDHB mutations correlate with higher metastatic risk.
SDHB means watch out for Mets.
Exactly. Changes surveillance. Pearl 3. Gallium-68 dotatate PET-CT is preferred for staging multifocal or hereditary disease. Finds those other spots.
Dotatate for staging.
Yep. Pearl 4. Standard radiation doses, 45 to 50.4 gray EBRT or 12 to 15 gray SRS margin, but near critical structures.
Hyperfractionate.
Consider 24 to 27.5 gray in 3 to 5 fractions as a safer hypofractionated option. Spare those nerves.
Now for Gray's ophthalmopathy, here are the essentials that will guide your clinical decision-making. Pearl 1. We're generally using 20 gray in 10 fractions during the active inflammatory phase.
20 and 10.
Often with steroids, targeting inflammatory diplopia and compressive optic neuropathy. Pearl 2. Counsel vigorously. Smoking worsens outcomes, both the disease and the RT response.
Gotta quit smoking. Non-negotiable.
Address it directly.
Pearl 3.
Be cautious. Generally avoid radiation in active diabetic retinopathy. Potential to make it worse.
Good point. Contraindication.
Right. Pearl 4. And if a patient presents with compressive optic neuropathy,
Urgent.
urgent treatment needed, including prompt radiotherapy to preserve vision. Medical emergency.
For hemangioblastoma, keep these critical points firmly in mind. Pearl 1. SRS targets only the enhancing neural nodule.
Nodule only, not the cyst wall. Classic board trap.
Exactly. Don't fall for it. Pearl 2. Typical SRS, 16 to 20 gray single fraction, but near critical structures.
Fraction it again.
25 gray in 5 fractions is a safe fractionated alternative. Maximize safety. Pearl 3. Crucially, counsel patients on possible transient post-SRS cyst expansion.
Warn them it might swell temporarily.
Yeah, may need drainage. Manage expectations.
And finally, for pterygium, let's not forget these key elements of adjuvant management. Pearl 1. Adjuvant strontium 90 brachytherapy is most effective when delivered very early.
Within 72 hours of surgery.
Ideal timing. Catch those fibroblasts. Pearl 2. Common regimens. 30 to 36 gray in 3 to 4 fractions, or 20 to 22 gray in 2 to 3 fractions.
Couple of options there.
Delivered superficially. Pearl 3. Pair it with optimal surgery, autograft, mitomycin C, and meticulous lens shielding is paramount.
Surgery plus RT plus shielding.
The whole package for high-risk cases.
Ready for a quick board blitz to test these concepts and ensure you've really locked them in?
Let's do it. Fire away.
Okay. I've got 3 questions for you, designed to highlight exactly what you need to know. Question 1. Which pretreatment test is mandatory before any invasive procedure for a patient with a head and neck paraganglioma? Is it A, serum catecholamines only, B, plasma-free or urine fractionated metanephrines, C, routine cortisol, or D, none, functional tumors are rare?
Okay, that's a classic, and we hammered this one home. It's B, plasma-free or urine fractionated metanephrines. The clinical reasoning is simple. Missing a functional tumor risks that catastrophic hypertensive crisis. Screen universally, period.
Correct. Absolutely critical. Question 2. When is adjuvant strontium 90 most effective after excision of a pterygium? A, 6 to 8 weeks postoperative. B, immediately to within the first 2 to 3 days. C, 1 year postoperative, or D, timing does not matter?
That's B, immediately to within the first 2 to 3 days. The reasoning, as we said, is hitting those rapidly dividing fibroblasts early, right after surgery, before they can repopulate and cause recurrence. Timing is everything there.
Exactly right. Timely intervention is key. And for our last board blitz question. Question 3. You are planning SRS for a cerebellar hemangioblastoma that consists of a 1 centimeter enhancing mural nodule and a 3 centimeter associated cyst. What is the appropriate GTV, or gross tumor volume, to target? A, the entire 3 centimeter cyst. B, the 1 centimeter enhancing mural nodule only. C, the nodule plus the entire cyst wall. Or D, a 5 millimeter margin around both the nodule and the cyst.
The correct answer is B, the 1 centimeter enhancing mural nodule only. The clinical reasoning is fundamental. Treat the active tumor, which is the enhancing nodule. The cyst wall is reactive, not tumor. Targeting only the nodule is key.
Perfect. You nailed all 3. Important distinctions to remember.
That board blitz really did hammer home some key points. But thinking about these conditions, there's always evolving knowledge, isn't there? New treatments emerging.
Always. The field never stands still.
For instance, with Graves' ophthalmopathy, we mentioned teprotumumab. How do you see the role of radiation therapy continuing to evolve alongside these targeted systemic therapies, especially for something like inflammatory diplopia? Is it, competition or more complementary?
That's an excellent point, and it's a very dynamic area right now. I really think it's largely complementary rather than direct competition.
Okay.
While newer systemic agents like teprotumumab are certainly exciting, especially for managing proptosis and the overall inflammatory score, radiation therapy still holds a very strong and, importantly, clinically validated niche for specific symptoms like inflammatory diplopia.
Where we have that randomized data.
Exactly, where randomized data has shown its clear benefit. The challenge, and maybe the exciting evolving area, is in better defining which patients benefit most from which modality, or perhaps a combination. Optimizing the sequencing.
How to best integrate them.
Precisely. And minimizing cumulative toxicity. We're looking for synergies, not necessarily replacements. Also, thinking about paragangliomas, as genetic testing becomes more widespread and we understand the specific mutations better, like SDHB,
Right.
will that lead to more personalized, mutation-specific systemic therapies down the road that might alter our radiation indications? It's really an exciting time of integration and refining our treatment algorithms, combining strengths.
I agree. The integration aspect is truly fascinating. And with meningioblastomas and VHL syndrome, the understanding of the underlying genetics and pathways is growing so rapidly.
It really is.
Could we see advancements in targeted therapies that might reduce the need for surgery, or even SRS for some smaller or multiple lesions? Or perhaps, agents that specifically prevent that post-SRS cyst expansion we talked about.
That would be fantastic.
Right. These are all areas where our knowledge and treatment paradigms will surely continue to advance, pushing the boundaries of what we can offer our patients, perhaps making our interventions even less invasive in the future.
It's a field constantly pushing forward, always looking for better, safer options.
Today, we've conducted a comprehensive review of 4 important benign CNS and orbital conditions that are crucial for every well-rounded radiation oncologist to understand thoroughly.
We covered the nuanced management of paragangliomas, detailing conventional doses of 45 to 50.4 gray, or 12 to 15 grays with SRS, and highlighting the absolute importance of biochemical screening and SDHX genetic testing.
We then reviewed the critical role of 20 gray in 10 fractions for inflammatory Graves' ophthalmopathy, emphasizing the critical impact of smoking cessation on outcomes and the urgent need for treatment in compressive optic neuropathy.
We also connected VHL syndrome to CNS hemangioblastomas, explaining their treatment with SRS to 16 to 20 gray, and reminding you to target only the enhancing mural nodule, not the cyst wall, and to counsel patients on potential transient cyst expansion.
Finally, we discussed the specific application of adjuvant strontium-90 brachytherapy for recurrent pterygium, noting its optimal timing within 72 hours of excision and typical regimens of 30 to 36 gray in 3 to 4 fractions, always with meticulous lens shielding.
We truly hope this focused session into these rarer benign conditions has provided valuable insights and strengthened your understanding, giving you that essential edge in both practice and board preparation.
Remember, you can complete practice oral boards at radonsmartlearn.com. That's R-A-D-O-N-K smartlearn.com.
And be sure to subscribe to Radonc Smart Review for our next session, where we'll tackle CNS case-based review.
Thanks for tuning in. Until next time, keep learning, keep growing.